And you see his right foot is atypical. It shows a specific deformity. We will see what that means. But Sienna, in arts, you have very often, you know, signs of deformities of people. And the next guy, probably many of you have heard about, Quasimodo. You know, it's a well-known person in you know, telling stories and musicals. And what we know about him, that he had his hump. And why is that there? And imagine this is a muscle problem also. We will speak about it in some minutes later. So if you look around in the world, you will see deformities everywhere. You will see problems which are visible. And most of them have to do something with the musculoskeletal system, and most of them are originated in the problem with muscles. There is a muscle on our neck which everybody can palpate. Here you can see this muscle outside. Yes, on Siena's muscle I even see here through the camera. Yeah, it's very well visible. Thank you for demonstration. This muscle you have not learned yet, but you will learn about it in the future soon in anatomy. It's called the Sternocleidomastoid muscle. The name is because it comes from the processus mastoideus of our skull, and it's going down to the sternum and the clavicula. That's why it's called that. Well, okay, there is this muscle, but imagine that there is a deformity of that muscle in newborn babies. They are born with a muscular problem. It is called Vryneck or torticollis in its original Latin name. And soon after birth, what you can see is that the muscle on one side, mostly it is unilateral. So one side, you see that this muscle is very tense. It is thick. It is over functioning. And because of its over functioning, the baby is looking in one, the head is turned into the opposite direction of the affected muscle. And later on, when the baby is developing, the head is even in a tilted position. Like you can see here, the muscle is not so well visible, but because of the strength of the tense muscle, the head is turned on one side. Of course, here we are speaking about cases where the problem is not handled, it is not solved after we have detected it. And later on, it can be even worse. It can be connected. Here you see it very clearly how this muscle is over functioning on one side. The child is a little bit turning the head into the opposite direction. The head is a little bit tilted towards the pathologic side. And you see also an asymmetric face. So this muscular problem, if you don't solve it, this muscular problem is having lots of consequences if it is not treated, ending in a complex deformity of the head, which is not so nice. So you should be aware of the problem and you should be able to handle it. But for that, you have to know anatomy. You have to know where the muscle is attached, where it goes down, what other anatomical structures are around the sternocleidomastoid muscle. Is anybody who has an idea here how to solve the problem in a very, very simplified way? Can anybody give me an idea what we could do with that situation? The muscle is too tense. It is shortened and it is tense. What should we do? Very simple solution. Don't be afraid. Yes, somebody?
Cut it out.
Yes, cut. Very easy. Cut. Take a knife. Take a knife and cut. It's simple, but finally that's the solution. Of course, you have to do it somehow carefully because there is some aspects which you should be considering, but the final solution is to take a knife and somehow cut. And imagine there have been people who were brave enough hundreds and hundreds years ago when they detected this deformity or any other deformity, they took their knives. They were not doctors, they were maybe barbiers or some other people with knives, and they tried to do it. Of course, their anatomical knowledge was not so good that they knew about vena jugularis interna, for example, which is immediately underneath this muscle. So there could have been some problems also with cutting this muscle. But if you do it nowadays, you should be aware of this big vein. You shouldn't destroy it because then you will have problems. But the final solution is to somehow release the tense muscle in babies very early, and then you can solve the problem. And imagine how far this went, this cutting of a muscle. There was a French guy in the 18th century who said that there is an art. It was his expression. There is an art to prevent and treat deformities of the body in children. His name was Nicolas Henry, and he made this interesting, painting or drawing of a very, very thin little tree supported by this stick to hold the structure of the tree. This is nowadays everywhere used in the world as a symbol of orthopedic surgery because his work he called orthopedy. It was the first time that somebody used that term, and he combined the words, the ancient Greek words of orthos, which means straight, and paidos, which means child. And he figured out an expression which is called orthopedics. So, what we do nowadays, millions of people all over the world, is coming from the situation that there was a deformity. There were some people who realized those deformities in children and tried somehow to solve the problem, somehow to treat these deformities. And the new subject, well, okay, I could say a new science, but we are not scientists, we are doctors. But a new subject developed, which is nowadays called orthopedics. So very interesting connection of of the situation. Well, let's see another example of how the muscles can influence a situation and how far it can be going. The bony spine you have already learned, haven't you? You have learned it. We know that our bony spine is in the frontal plane straight. When we look it from the back or look it from the front, it's mostly visible from the back in the patient, then it should be straight. In the side view, in the sagittal view, it should be curved. There are physiological curves in our spine, in the bony spine, which we call kyphosis and lordosis. And those curves are features of a normal spine. But for maintaining the straight spine in a frontal plane and these curves in the sagittal plane, you need muscles. Without the muscles, it wouldn't be in that position, the bones. Normally, bones are just in their position when they are held together by ligaments and they are positioned or functioned by muscles. You will learn a lot about the muscles of the trunk from the back. It is a pretty complicated system with deeper and superficial layers. You have to learn about that one. It will come soon. And I would like to have you remembering my speech when you learn about that. Because if you don't know about the function of these muscles, if we wouldn't have these muscles functioning properly, then our bony spine will not be in a normal position. It will not be in a straight position in our frontal plane, and it will not be curved in the sagittal plane. And now we come to the expression which Sienna already has heard before, the deformity of the spine called scoliosis. We can see it very well. If you look on the picture of this adolescent girl, you see the curve of the spine from outside. It is not the only thing what you can do, of course. You can nowadays do an X-ray, and when you do an X-ray, it is even more visible, and the curves can be very, very, bad and really pronounced big curves. It is not only about the aesthetical problem. It is not only about the curve of the spine itself. Since if we have this deformity in our thoracic spine, this curve in our thoracic spine and the deformity of the spine, of the bony spine, it is also connected with the deformity of our chest. You see here a horizontal view of of one segment of the chest of a scoliotic patient. It is a drawing. So you see how asymmetric the ribs are, how deformed the ribs are, and there are some organs inside, sometimes needed organs like lungs, hearts, even men have hearts, ladies, okay, don't forget about that. Sometimes it is very difficult to see, but it's really there. So there is, in both genders, there is some organs which are necessary for living. And you can imagine if somebody has a deformity of the chest, these organs cannot function well. So there will be a long time consequence of scoliosis, muscular problem, secondary deformity of the spine, scoliosis, third, deformity of the chest, fourth, insufficiency of the cardiorespiratory system, insufficient function of the lung and the heart. And the final consequence is that those people, and it starts in childhood, in adolescence, those people will not become 80 years old if we don't treat the problem, because the heart and the lung will give up after a certain period of time. And if we come back to the view from the back, we even see this deformity of the chest. It is called a rib hump because it is formed by the ribs. And it is not only the scoliosis, it is also even more important, it is the deformity of the chest, which will cause a problem. And if we look at poor Quasimodo, he had this rib hump. He didn't become 80 because he, sacrificed himself for his love, which is also a sign for man having a heart. And he sacrificed himself for his love, Esmeralda. But if he didn't do that, wouldn't have done this, then he also wouldn't have become 80 years old, because with this rib hump and chest deformity, your life expectancy is, of course, shorter than if you don't have that. So how did it start? It started with the muscular problem of the trunk muscles, deformity of the bony spine, deformity of the chest, and a life-shortening situation which you have treated. How would you treat it? If something is curved, which shouldn't be, then you have to straighten it. Nowadays, spine surgery is a big, big field of orthopedics. It is even in some countries an almost separate field, but it still belongs to orthopedics. So spine surgery, one of the goals of spine surgery is to correct these deformities. Nowadays, we have very, very, fine techniques and well-developed techniques to straighten the deformed spine. It is a very, very big achievement of orthopedics nowadays that we can give back the normal form of the spine to the adolescent young people, and with special surgical techniques, special metal implantations, we can correct the spine. And now Come back to the old style. Forget about Facebook, forget about Messenger, forget about all this technical super stuff which we have nowadays, and just make a drawing. Take a paper, make a drawing, and look how actual this 300-year-old drawing nowadays is. If you compare the situation which we do with modern technique to the drawing which Andre did 300 years ago, and he really smart, he had a really smart way of thinking, and he symbolized at those times already what we are doing now, how we are supporting a structure which is deformed, which is weak, and how we can try to correct this deformity. So it is very, very interesting. Well, this muscle you have already learned. Who can tell me the name of the muscle? I am not making exams in anatomy. So if you're telling something wrong, you will not get any bad result from me. You have already learned this muscle, I know. It has 4 heads. That's the name of the muscle in Latin language.
Sorry, I can't cursor, but it's the quadriceps.
Yes, Sienna, this is the quadriceps. You cannot hear me really? Is
No,
there something?
I couldn't see your cursor on the screen. It's like where
Okay. This is we're speaking about the muscle of the thigh in a frontal position. Yes, Sienna. It is the quadriceps muscle. It has 4 heads. What are the 4 heads of the quadriceps muscle? There is 3 which have the same name.
Vastus lateralis, intermedius, and medialis.
Very good. And what is the cuckoo's egg? There is a 4th one, which is not really the same like the other 3. It has another.
Femoris?
Yes, rectus femoris is the 4th one. Here it is visible. It is the most superficial one. Underneath the rectus femoris, there is the vastus intermedius. Who can tell me what the difference is between the rectus femoris and the other 3, the vastus muscles? Does anybody know the difference? Not only the name. There is an even more important thing. Well, this is an example for knowing an anatomical difference which has clinical consequences. The difference is that the rectus femoris has its origin on the pelvis. The other 3 have their origin on the femur itself. So the rectus femoris is going over 2 joints. It is bridging 2 joints. The other 3, they are bridging only the knee joint. Because what is the function of the quadriceps femoris? When you learn anatomy, please always learn the function together with the muscle. Because we have muscles for function. They are bridging, the quadriceps femoris is bridging the knee joint, and the quadriceps femoris is responsible for extending our knee. You are doing that every day, many, many times. You are straightening your knee, and it's happening because of the quadriceps femoris. But the rectus femoris on the upper part of the muscle is coming from the pelvis. The other 3, the vastus 3, they are coming from the femur. Okay, you would say this is just an anatomical difference. Who cares? Not so interesting. Let's see what kind of consequences does it have. You are sitting in your outpatient clinic, and because you want to become doctor, as I know, huh? Many of you would like to treat patients. Okay, that's our goal. That's why we learn. So you are sitting in our outpatient clinic, and a child comes in with the mother, and you see that the child is limping. It's not walking normally. It cannot really it cannot really bend the knee. cannot do flexion in the knee joint. And if you cannot really bend your knee joint while you are walking, then you will have problems during walking, during gait. And interestingly, some years ago, when I was checking the Sobota Atlas, which you probably also use for anatomical studies, there is a drawing. Everybody jumps over that because it is not so interesting. But for me, it was interesting to see that even in the Sobota Atlas, it is demonstrated what you should do when you put in an intramuscular injection. This is one of the basic things a doctor can do treating a patient everywhere in the world, even in the jungle somewhere when you are, I don't know, on an expedition with a scientific team and somebody has some problems and you are the doctor of that expedition. You have to be, able to put in an intramuscular injection in the muscles. Where you put it, that's the question. And the Sobota demonstrates us that you should put it laterally if you put it in the thigh. You put it on the lateral side, in the vastus lateralis. Why? Because if you do it another way, if you put it more anteriorly in the frontal part of the thigh, you can cause, with every intramuscular injection, especially if you are repeating it many times, you can cause some scar formations. If you are, muscles, if they are injured somehow, they will be scarred and they won't be elastic as they have to be during the movement of the joint. So if you here you see a child which has had lots of intramuscular injections, and if you put in lots of those in the muscle will lose its elasticity and it won't be able to extend when you are bending your knee joint. So the reason for not be able for flexion to the knee joint during walking might be scar formation in the quadriceps femoris. Now, the quadriceps femoris gets a clinical importance. The problem is here in this muscle, somehow caused because, for example, because of injections. You examine the patient, you lay the patient on the table, try to bend the knee, and it's not possible. The flexion of the knee joint is only this amount. It is not fully flexible. Okay, what would you do? You are a surgeon, you take your knife and try to lengthen that muscle somehow, which is possible. There is techniques for that. Okay, you admit the patient to the orthopedic department. The grand round is coming. The professor is doing visits, controlling everything very, very badly and strongly and checking everything if you are working well and your diagnosis is okay. And he comes to your patient. What does he do? Okay, he just bends the knee joint. Suddenly, the flexion in the knee joint is possible. The professor says, "You are stupid. This patient has not been treated. The flexion of the knee is possible. What do you want to do here? You haven't learned anything, no idea." What would you do, Paul Daniel? You would say, "Professor, sorry, I have learned anatomy, and I know what you do now here is that you bend the hip at the same time. It is not the situation what we see here. Here the hip is not in flexion. Here in this situation the hip is in flexion. And professor, this patient has the problem only in the rectus femoris muscle. Because if we bend the hip joint, the rectus femoris muscle will become loose. It will be here. It won't be tight, as in the situation when the hip is extended. So, professor, I am right. The patient cannot bend his knee if the hip is flexed. And because I know anatomy, I have learned it when I studied at University of Page Medical School. I learned that the musculus rectus femoris is bridging the hip joint. So if I have some scar formation only in the rectus femoris, you can bend the knee if the hip is also in flexion position. And I know that in this situation, the problem is only in the musculus rectus femoris. If I do surgery, I have to treat only the musculus rectus femoris. If in this situation when the hip is also flexed and I cannot bend the knee joint, then I know that the problem is in the vastus also. So I have to do a more complex surgery to give back the flexion to the patient. Paul Daniel, is it worth learning anatomy? You know, it can help you in some critical situation if you know what the difference between those four muscles is. Okay, let's see another example of muscles influencing situations of bones. This is the foot. The muscles of the foot you have not learned yet, I guess, but you will soon. And you know, in the foot there is muscles on the lateral side of our foot, and there are muscles on the medial side of the foot. On the medial side there is a very important muscle, the so-called musculus tibialis posterior. You will learn about that and remember me when I'm what I'm saying now, that you know, if you have muscle imbalance on your foot, if the muscles are too strong on one side or too weak on the other side, our foot will not be in a normal position. Our foot will be pulled into the direction of medial or lateral side if some of the muscles are over functioning or on the other side under functioning. This is very simple to understand. So if the musculus tibialis posterior, which is on the medial side of the foot, is pulling too much, then our foot, the forefoot, the metatarsal bones and our toes will be pulled into midline of the body. So we have a foot deformity, which is very well visible here on the schematic drawing. It is very well visible on the X-ray, and it is really interesting that when we come back to that interesting mushroom, now we see a similar situation. And now we know that that guy who first saw this mushroom had any idea about clubfoot, because the first thing what he figured out seeing this mushroom was clubfoot. He said that's why we call it the clubfoot mushroom. Okay, look the similarity in case of a clubfoot in a newborn, because this is a congenital deformity of the foot. It is visible immediately after birth. What happens? The muscles on the medial side are over-functioning. It is an innervational problem, which we will learn later when you come in the fourth year to orthopedics. You will learn about that the overfunction of the muscles on the medial side will result in this interesting deformity, which we have to treat immediately in order to avoid problems. For that, you have to know where the tendons of these muscles are on the medial side. This is a foot of this size. So you have to have anatomical knowledge to figure out where the tendon of the flexor hallucis longus, the flexor digitorum communis, and the musculus tibialis posterior is, to avoid the situation, to lengthen these tendons, and to give back the normal position of the foot. If you do that well, then the patient will have a normal foot situation. But if you look at the pictures, and this is an absolute clear, demonstration of a muscular problem. This is a unilateral clubfoot. This is a bilateral clubfoot. It can be both. But you see on the unilateral side the big difference between the calf muscles. You see how this is the normal calf muscle, and you see this underdeveloped, weak, not so strong muscle, which will remain for the whole lifetime because it's an innervational problem of the muscle. And in the bilateral situation, you see how underdeveloped the muscles are on the calf, which results in the deformity of the foot. If you don't do it, if you don't treat it, this happens. This is a neglected case. In Hungary nowadays, fortunately, you don't see neglected cases like these anymore, because the prevention and the surgical skills are now much better. But in the mid 70s, it happened sometimes that that just a 14 or 12-year-old showed up with a deformity which lasted for a decade and nobody has treated it. So look the pathological function of the muscles of the calf, and look what kind of consequences it can have, what kind of deformity it can have, because with this food it is very difficult to live a normal quality of life. Let's see another example for a muscle problem which is even more complicated. Here I demonstrate you three different regions. This is the hip, the adductor muscles of the hip, double D. This is the posterior view of the thigh, the bending muscle, the flexors of the knee joint. And this is the calf muscle with its very, very strong tendon going down to the calcaneus called, how is that called? Everybody.
Achilles?
Yes, this is the Achilles tendon. Brad Pitt was Achilles in the movie Troya, okay? Remember Brad Pitt, then you will know Achilles, okay? So Achilles tendon is the tendon which is responsible for plantar flexion of our foot in the ankle joint. When can happen a complex problem of the muscles? If there is a central nervous innervational problem. These are the spastic people. It is called infantile cerebral palsy or paresis. Immediately after birth, it has to do something with the circumstances around birth mostly. An innervational problem because a central nervous problem, we will learn about that, but it has absolute consequences on the muscles of the lower extremity. If you check the sagittal plane, you see a flexion situation in the hip, a flexion situation in the knee joint, and a plantar flexion situation in the ankle joint. And this is not because the patient wants to hold it in this position. It is not possible to do full extension even if you do it as an examiner. So you cannot passively do the full extension. This is because the Achilles tendon is over functioning. Here you see the flexors of the knee joint. It is even visible. So the bending muscles of the knee joint. And here the flexor muscles of the hip joint, mostly the musculus iliopsoas, which you see here on this schematic picture, are over functioning, and that's resulting in this very bad position of the extremity. If you look at it in the frontal plane, the adductors, double D of the hip, result in a deformity in the hip joint that the patient cannot do abduction. So it cannot take away from the midline the thigh. And, it's a very complex situation. So in some children, both lower legs are affected. In some children, only one is affected. In some, the upper extremities are also affected, depending on the extension of the central nerve injury. So you have always to take in consideration those muscles which are influencing not only the function of one joint, but the function of more joints, like the rectus femoris. Here, we have spoken about it before. It is influencing both the function of the hip joint and the knee joint. The musculus gastrocnemius is influencing the function of the knee joint and the ankle joint. So if you do surgery, you always have to consider how those muscles are influencing joints, because your aim is to somehow lengthen those muscles, somehow take off the attachment of some of the muscles, but you always have to be aware of the complex situation of the complete lower extremity when you do surgeries, and you have to do the muscle function, the muscle functions. If you are treating properly, then you can solve the problem in the joints, and you can give the child back a normal standing and close to normal walking position. It is not completely normal always, but it's much, much better than if the child would have this deformity. If you don't treat it well, for example, the adductor overfunction, here is all the adductor muscles. If you don't treat it, they are so strongly overfunctioning that the hip even can become dislocated gradually. So the femoral head goes out of the acetabulum, which is a very, very bad situation because it hurts and the patients cannot really use their hip, and these are children. So overfunction of the muscle in an untreated situation can lead even to the dislocation of the femoral head from the acetabulum. There are not so severe cases in cerebral palsy. This child is a kind of a simple situation. There is only problem in the ankle joint. It is called pes equinus because of the horse position, horse-like position of the foot. So it is a deformity of the ankle joint, an overfunction of the Achilles tendon because it is too tight. It is pulling up the heel, so the patient cannot really put down the heel on the ground. So the child is not walking on the tiptoes because it wants to walk on the tiptoe. It is impossible to put down the heel on the ground for this type of children. Here you see how tense the Achilles tendon is. This is during surgery, old type of surgery with opening up, seeing how tense the Achilles tendon is, lengthen it. You should not cut because if you cut, then the function will be completely gone, which is not good. You have to lengthen the Achilles tendon. Nowadays, we can do it in a percutaneous way. We don't have to open up, so we just do some little cuts into the Achilles tendon, and it is possible just to slide the fibers of the tendon parallel to each other. Paul Daniel, do you want to see this surgery? Really? Okay, it will not be very long, okay? First, I have to take away the little red dot. Sorry, take it away. And now we do surgery, okay? You are assisting Paul Daniel, okay? You are my assistant. You see how tight the Achilles tendon is. No dorsal flexion in the ankle joint. Here you see how tight it is. You take a knife. The patient is under anesthesia, okay? I want relax. The patient is not having pain. So you do a little cut into from the midline of the Achilles tendon laterally on the distal part of the tendon. You do a little cut on the proximal part from the midline, also laterally, and in between from the midline, a cut into the medial direction. So you just cut half of the Achilles tendon in different directions, and then you just take your power and just slide the Achilles tendon, slide it, slide it, slide it, and the fibers are sliding away parallel to each other, and you can achieve dorsal flexion. So it is a kind of a simple surgery. Thank you for helping me, Paul Daniel. I think it was successful surgery. So we just had the Achilles tendon lengthened. In the dorsal flexion position, you have to put on a plaster cast because you have to maintain the normal dorsal flexion of the ankle joint till the fibers are normally repositioned and scarred, and then you solve the problem. Maybe for the first look, it's a little bit brutal to you, but for those children, it is very important to have short surgeries. It doesn't take too long, and they shouldn't be too long under anesthesia because of the central nervous affected parts. So you should do it fastly, and that's why these percutaneous surgeries are successful. Okie doke. I hope I could give you some impressions why anatomy, the knowledge about muscles is important. So when you learn, it is not only for the exam. You will use it later on. You have to know about it. So it is important just to have knowledge about anatomy. Okay, thank you for your attention. If anybody has some questions, please ask me. I don't know if Bayern Munich will beat Paris Saint-Germain on I don't know, is it today or tomorrow? I have no idea. So I cannot answer you these questions. But maybe if you have some questions about anatomy or about surgery, then I can give you some answers.